So whenever anybody hears chest pain in the ER, they immediately think of ACS, acute coronary syndrome. Is this patient having a heart attack? Is this patient at risk of having a major heart attack in the next few days? And that's what we want to rule out with patients that present to the emergency department. So again, the first thing you want to do is obtain a 12-lead ECG. The reason we're doing this is we're looking for ST elevations. So if you see P, QRS, T, P, QRS, T, this is normal. This is what you want to see. We're looking for any elevation. So P, QRS, elevated ST, T wave. P, QRS, elevated ST. Again, we're looking at this ST segment compared to the next TP segment. If I have greater than 1 millimeter of elevation in 2 contiguous leads, so 2 leads that would fit with the same coronary artery, that is a STEMI. Exceptions V2, V3. For men, you can go to 2.5 millimeters, depending on their age. Women, you can go to 1.5 millimeters. Read on that later. Right now, anybody that has 1 millimeter of elevation in 2 contiguous leads, that is a STEMI, and it needs emergent intervention. The interventions we'll do in the ER are aspirin. We'll get 325 of aspirin in them, have them chew them up if possible, and then activate the cath lab. This patient needs acute intervention to open up that coronary. If you can't do door to balloon in 120 minutes, you need to give thrombolytics. The other things you can consider in the ER are heparin. I give heparin. I bolus heparin to all my STEMIs. Just make sure you communicate with your cardiologist and let them know if you have or have not done that, because they will need that before they go to cath. The other thing you can consider is a second antiplatelet. Cardiologists vary, cardiothoracics vary, whether they want this before the cath or not. Always ask your cardiologist. Typically at our current shop, we do not give a second antiplatelet in the ED, but at other shops, they want a second antiplatelet agent on everyone that comes in with a STEMI before the cath. Talk to your cardiologist and consider that. And then finally, get pads on the patient. This ventricle does not have oxygen and it is dying. It is very prone to ventricular dysrhythmias. They can go into VFib, they can go into VTAC, they can die in front of you. If that happens, you don't want to be caught unprepared. Get the pads on this patient so that if they do go into VFib, you can immediately provide electricity and cardiovert them, defibrillate them. This is the basics of how we're going to do a STEMI, and that's why we're looking at that EKG to look and see if they have a STEMI. Now let's say they don't have ST elevations on their the EKG, then how do we work them up? Well, we use the heart score. The heart score is spelled out HEART, and this is going to allow us to risk stratify the patient. First, we're going to do our history. All of these will give you 0 to 2 points, depending on your suspicion. If you're slightly suspicious, you get a 0. If you're highly suspicious, you get a 2, and in between is going to be 1. Take a good history. Next, we're going to look at ECG. Even if you don't have ST elevations, you may have some concerning findings for some ischemia. If you have any dynamic process, if the ST segments have gone down and then come back up or moved at all, that's the dynamic EKG. That's very worrisome. That would get you a 2 over here. Obviously, a STEMI would get you a 2, but we're not going to bother with the heart score on those patients. And then if it's stone cold normal, you get a 0. If you have some subtle things that you're not sure of, you give them a 1. The next is going to be the age. If they are less than 45, they get 0 points. Greater than 65, they get 2 points. And 45 to 65 is going to get 1 point. The next is going to be the risk factors. And that's why we're taking such a detailed history to get these risk factors. Again, the high risk factors for ACS: hypertension, hyperlipidemia, diabetes, smoking, obesity, strong family history of ACS, mom, dad, or brother and sister that have had a heart attack. Those are all the risk factors we care about. If they have none of those, obviously they get 0 points. If they have 1 to 2 risk factors, that gets you 1 point. If they have 2 or more risk factors, they're going to get 2 points. And then finally, you want to get your troponin levels. If it's completely undetectable, you get 2. If it's intermediate, you get 1. And then if it's significantly elevated, you get 2 points there. That's why all these patients are going to get a troponin if we're concerned about ACS. So now what do I do with the heart score? If it is greater than or equal to 4, we typically admit them. With the new high sensitivity troponins, There are pathways where these patients do not have to be admitted. They're not quite ready for prime time yet at our shop. We typically admit these for observation, cardiology evaluation. Occasionally, cardiology will come down to the ED and see the patient and clear them for discharge if they're in this intermediate range of like 4 to 6. If it's less than 4, then we can potentially discharge. And here are the caveats. We do use the high sensitivity troponin assay. So with the high troponin sensitivity, troponin assay, if their heart score is less than 4 and their chest pain started greater than or equal to 3 hours prior to that being drawn, you're done. You can discharge them. These are the most recent recommendations that came out in 2020. If you're using high sensitivity troponin and it's negative and their heart score is less than 4 and the onset of chest pain was greater than 3 hours, you're done. You can discharge them. If their chest pain started less than 3 hours prior to that being drawn, then you need to check a second troponin. Right now, with the high sensitivity assays, you can do your delta troponin at 1 hour. The 2020 guidelines clearly state if you're using the high sensitivity assays, you can do your delta trope 1 hour after the first one. If you're using more traditional assay, you need to do a 2-hour delta troponin. But at our current shop, we have the high sensitivity trope, so we're going to do a second one after 1 hour. So the question is, what if their chest pain started an hour right before this was drawn? Do I need to do a 2-hour delta? Per the 2020 guidelines, you don't. You still do an next troponin 1 hour after the first one. However, personally, I like to have a troponin that was drawn 3 hours after the onset of chest pain. So if they came in an hour after it started, I am going to drag my feet a little bit and I'm going to do a 2-hour. The guidelines say 1 hour for everybody. If it started 5 minutes before they got there, you can still do a 1 hour delta. I'm always getting a troponin, me personally, 3 hours after the chest pain started, just to be absolutely sure. These are the most recent guidelines for ACS that came out in 2020. There are pathways now where a heart score of 4 to 6 can be safely discharged. However, they're not easy to understand. They're not easy to navigate. I do this in conjunction with cardiology at times, but I want cardiology to see the patient. If cardiology tells you to send them home over the phone, liability-wise, they carry no liability. You're the only one seeing the patient. If the patient has a heart score of 4 to 6 and you're worried about them, admit them. If the cardiology wants to clear them and you're worried about them, they need to come to the bedside and see the patient to clear them. That's the very basics of ACS. Again, the other things I'm going to do is I am going to check a CBC. If I have a coronary artery that's half blocked and most of the time enough blood gets through that I don't have symptoms, if all of a sudden my hemoglobin goes from 12 down to 6, cut my oxygen carrying capacity in half, and now they may be having chest pain from this chronic occlusion. So you always want to get a CBC so that you know what your hemoglobin and your hematocrit are, because you may need to transfuse and then work them up for ACS later. If they're having unstable angina, if they're having an NSTEMI, so persistent chest pain, continual chest pain, elevated troponin, but no obvious ST segment elevations, then you may have this. You may have a partially occluded coronary artery that's now causing symptoms. This patient needs heparin, and you need to talk to cardiology emergently. They may need to go to the cath lab emergently. Probably not. Usually NSTEMIs go to the cath lab the next morning or when they can get them in, but they need to be on a heparin drip and probably admitted to the cardiac ICU. This is the very, very basics of ACS, but it's what you got to know.